How is the recording available afterwards?
We've got a channel online that we share all the videos.
Okay. Just know, I think some of my trainees are actually not able to make it either, so they were asking about recording. So you couldn't, you may have already sent me it, but could you send me the link again, please?
Yeah, I'll do that after the meeting.
Thank you. So it's 3 o'clock. Let's just kick off. So I'm going to just move. We've obviously done hydrocephalus. I'm just going to spin through down to through the hydrocephalus stuff and through the sort of start of the calcification talk. Thanks everyone for joining today. So we got through a little bit of the abnormal calcifications last week, starting with the vascular lesions. So I'm going to start here actually. So we're looking at abnormal calcifications, and then we're going to look at post-operative appearances today. So I showed the list last week, and we got through cavernoma, looked at aneurysm, a little bit of AVM last week. So this week we're going to move on to this gigantic list. I'm not going to show an example for everything, but really just some examples on how to go about differentiating some things from others. So these are the vascular ones we talked about already. We got to calcified embolus. So let's start here. So moving on to neoplastic. So this is it's quite a large list, and in some cases you're not going to be able to tell what an intraaxial neoplasm is. You're going to actually have to have histology. So when you've got something that you think it probably is a tumour, then you should obviously correlate the imaging with the age, with the morphology of the tumour, and with the location, and that should help you to narrow the differential diagnosis. So in terms of location, we're thinking that the broad categories here would be extraaxial and intraaxial, because the differential for those compartments are completely different. And then there are other locations on that list which would lead you to think about particular neoplasms. So let's start with the extraaxial lesions which calcify, starting with these two. Oh, really going to concentrate on meningioma and cranial today, because these are two of the most common extraaxial calcified lesions. And of course you do have schwannoma and dermoid and epidermoid, so much less common. Schwannomas don't calcify very often. Dermoids would typically have fat in them and a bit of calcification, so the fat would be the key there. In epidermoid, you would tend to do a DWI MRI for that. On a CT, it would tend to look almost like CSF, but a little bit brighter or a little bit denser on CT than CSF. So let's go with meningioma. So this is a non-contrast CT, and it's the most common extraaxial neoplasm. And quite a high proportion of these are calcified, so up to about a third. But the calcification can kind of look like anything. So in this case, it's focal and it's fairly punctate, it's quite dense, but it doesn't have to be. It can be much more rim-like, it can be much less obvious, to be honest. And the meningioma on an axial CT, the typical appearances will be hyperdense to brain parenchyma. Now, this isn't particularly hyperdense, this lesion, and that can catch people out if it's not particularly hyperdense. The location, as we mentioned, extraaxial, so meningiomas tend to be either paraphalcine or along the convexities, and the sphenoid wings and the clinoid processes are also very common locations. So hyperdense mass, which looks extraaxial in a proper location, you say, okay, probably going to be meningioma. So this is a patient, this is the same patient actually, and this looks probably like it's actually centered on the clinoid, anterior clinoid process. When you have a lesion of this size, and you say, okay, it's calcified, you think, oh, is it intraaxial or extraaxial? It's so large, it can actually be quite difficult to say. In this particular case, has this got a broad dural attachment along the left cerebral convexity? Well, difficult to say again, when it's this size. I think you've got to just give it a best guess in these cases. So the dural tail that everyone talks about, you might see it on CT. You could probably like sort of imagine a little dural tail here. But on an MRI, you would see the dural enhancement much better. So you would do a post-contrast T1 to look for a dural tail for a meningioma. And if you had a meningioma of like sort of planum sphenoidale, or something midline, you would do a sagittal T1 post-contrast, as well as your usual axial and coronal post-contrast planes. But they are common, so if you do get hemangiopericytomas, which kind of look similar, which look even more aggressive. Meningiomas, if we go back to this actual image, there's a lot of edema here, which you don't always see in meningiomas, but you do in some. And when we talked about them being well defined, if you've got invasion, so sort of WHO grade 2, it might not be well defined. And it might be that you have a meningioma with no edema at all, but then a little bit which is starting to invade brain, which produces a little bit of focal edema. So again, that's typical for meninge. If you've got a meningioma that looks like this, so clearly quite a broad base against the phalanx, pretty obvious, it's heavily calcified, really can't be much else. This is much more straightforward. This image actually gives you a reasonable indication of whether you think it's intraaxial or extraaxial. So on imaging, the features that it's extraaxial are usually that you have compression of the underlying brain, and you might often see a little CSF cleft going around the lesion. So you don't see the CSF cleft here. You might see a CSF cleft if you did an MRI. So moving on to cranial. So craniopharyngioma, again, extraaxial, and it's quite common. They're grade 1 tumours, and 75% of them are suprasellar. So if you see a suprasellar lesion, I mean, this one obviously is quite extensive, think of cranial. Now you have two different types, so adamantinomatous and papillary, and the distribution of this is bimodal. So your age here is important. If you've got a teenager with this, you're going to say, okay, it's an adamantinomatous cranial. These patients also, combined with the location and imaging appearances, you'll have visual symptoms and hormonal imbalance if you actually check the pituitary profile. So the clinical symptoms are also important when you're trying to decide what these lesions actually are. So the kids get the cystic lesions, and the cyst doesn't have to be one single cyst. It can often be a multi-lobulated cyst, and it can be multiple cysts. But the important thing about kids with the cystic cranials, 90% of these calcify. And the calcification, again, can be quite variable. So in this case, it's kind of stippled. It looks a bit peripheral. In the adults, they don't tend to get cysts. They can get cysts, but they tend to have much more solid tumours, and they rarely calcify. But again, you're going to know the age of your patient. So if you've got a suprasellar lesion in an adult, think papillary cranial or pituitary macroadenoma or the various suprasellar lesions. So again, we're not going to talk about every single tumour on that list. Let's move on to the common intraaxial lesions that you might see with calcification. So I've highlighted these in blue. So oligos, very common and also very commonly calcified. Germ cell, pNet, ependymoma, ganglioglioma, pilocytics, and metastases. So I'm going to show almost all of these. I'm not going to show germ cell and pNet, but starting with oligos. So a high proportion of oligos will calcify. And again, calcification can sort of look like anything. So don't let the pattern of calcification doesn't really help you particularly. These tend to be cortical or subcortical. So this peripheral location here in the right frontal lobe is pretty good for an oligo. Non-contrast CT, they can be mixed density. So in this case, you can see hypodensity here, and actually more subtle hypodensity here, but none of this is isodense. This is all hypodense relative to brain parenchyma. And again, age helps a little bit for these patients. So 4th and 5th decades, that makes me middle-aged. And if you look on the bone windows, the overlying skull can have pressure effects. So it can look a little bit scalloped or remodeled. So again, that would push you towards it being an oligo and intraaxial rather than some sort of bizarre extraaxial meningioma. I'm going to briefly show a couple of slides on oligos in terms of the WHO grading. So this was updated only very recently, to be honest. And it involves, I'm going to show you this thing at the end, but it involves this IDH and 1p19q. So IDH gene mutation, keeping it very simple, it's a useful prognostic marker. for patients with diffuse gliomas. There are two types. So there's a mutant type, and this is most low grades and includes astrocytomas and oligos. And then there's this wild type, IDH. And so if you don't have IDH, you are likely to do worse. So because they behave much more aggressively, worse prognosis, and they're much more similar to GBMs. So that's IDH. The other thing that you probably should know about is 1p19q. So 1p is losing the short arm of chromosome 1, and 19q is losing the long arm of chromosome 19. And again, it's predictive of your therapeutic response to treatment. So that's not just chemo, but chemorads as well. And they have a longer survival. And if you have this combination, so you have a mutant and the codeletion, you have a better prognosis from your oligo. If you're IDH positive, but you don't have this chromosomal codeletion, you call it a diffuse astrocytoma. And there is this classification which is available to show you where you do the IDH testing. First of all, you do the sequencing for this mutation. You look at the 1p and you end up with these different classifications of tumour. So that's who grading 2016. So moving on, could this be an oligo? It could be. I mean, it's isodense, isn't it? It's also calcified, and it's obviously obstructing the right lateral ventricle as well as third ventricle, and it's producing obstructive hydrocephalus with periventricular low density. And you can see here that there's sulcal effacement. So this is an acute hydrocephalus. Maybe it bled, or maybe it's just been slowly progressing and eventually they've decompensated. But without histology, I think difficult to say if this is an oligo or an ependymoma. So this is a patient who had a pilocytic in the in the posterior fossa. So this isn't all fourth ventricle. Some of it is, but some of it's actually cystic lesion. And pilocytics don't always calcify. So oligos obviously do. But if you do see something that looks a bit odd in the posterior fossa, think, is it a pilocytic? And this was also causing obstructive hydrocephalus. Other intraaxial tumours, this looks less like an oligo. It looks almost more like a pilocytic, to be honest. Slightly more dense, well-defined calcification, a little bit of isodensity around about it, and then this sort of cyst with you do wonder if there's a bit of solid component here as well. But something to think about when you've got a calcified intraaxial neoplasm. So here's a patient with lung cancer. Now, again, could this be a primary tumour? Yes, it could. The patient in this case was known to have lung cancer, was known to have metastatic lung cancer. And they went on, and you would obviously go on to do an MRI in all of these cases, and there were no other lesions. There wasn't really edema, and basically because they had lung cancer, it was deemed to be a lung cancer metastasis. So what other metastases can calcify? We've talked about lung, obviously. So breast, quite common. GI, so mucinous adenos and sarcomas, as well as ovarian tumours. And the other thing that can catch you out, if you've had lymphoma or breast cancer and you've had treatment for these, you can have calcification afterwards. So don't forget about the ones which don't present often with calcification like lymphoma. Think about post-treatment change as well. So still on this neoplastic list of calcifications, so these calcify, and it's going to be quite obvious. If you see a lesion of the choroid plexus or in the pineal gland region, then you're going to think, okay, this could be neoplastic. So those are the two that will calcify off the rest of that list. So moving down the list, another 5-10 minutes just on calcifications. So metabolic and endocrine causes, these patients aren't going to come your way, but I think it's, if you're getting a lot of referrals for people saying, oh, what's this calcification? It's kind of nice to know that you can just bump them off to a neurologist or elsewhere. So Fahr syndrome. So Fahr syndrome basically is something that describes the CT appearances. So the CT appearances like this. So dense calcification, these are the dentate nuclei here down in the posterior fossa. The basal ganglia, so caudate head here, and lentiform nucleus, or globus pallidus, the putamen, the thalami here, bilateral thalami, and it's very symmetric, as you can see, and then subcortical white matter. So this is classic Fahr syndrome. You can also call it a very fancy term, so bilateral striatopallidodentate calcinosis. It's a bit of a mouthful. And lots of causes for this. So the primary one is also known as Fahr's disease, but the preferred terminology for this now is primary familial brain calcification, or PFBC. So that's Fahr's disease itself. And then the secondary causes we're talking about, lots of causes. So it doesn't have to be metabolic, it can also be infective or other causes. So massive list of lesions or etiologies for this bilateral symmetric calcification. So parathyroid and thyroid issues, again, pretty obvious clinically. Vasculitis, I've never seen it look quite so florid as this. Mitochondrial disorders, again, this is all neurology territory, isn't it? Infections are quite a good one to think about. Again, this would be probably too florid for previous infection with this extent in the basal ganglia. Inherited disorders, so ferritin storage disorders and cocaine syndrome. Again, post-treatment, so mineralising microangiopathy could look like this, again quite severe, but radiation and chemo can produce these appearances, and CO poisoning. CO poisoning tends to be more lentiform nucleus rather than as gross as this, to be honest. Again, history and clinical features are what it's all about to sort of decide which of these in the list is the issue. And this is a kid actually who had an ATRT, who had some radiotherapy as a child. And you can see very faint calcification. Now, the fact that it's bilateral should also make you think that it could be an endocrine or metabolic thing. So it's not really a focal, you know, if this person came in to Stepping Hill and was referred to you as query oligo, then you could actually find the other side being abnormal. You could suggest, well, you know, it might actually not be a unilateral lesion to be concerned about. So you'll probably see in our reports for these clinical correlation advised. So that's neoplastic finished. Just moving on to infection a little bit briefly about congenital. So infection, torch infections. So torch incorporates toxo, other infections, as you see there, rubella, CMV and herpes, and tend to be in utero. There's also neurocysticercosis and then granulomatous infections, so TB, so tuberculomas. And again, imaging appearances with a history is important. CMV, if you have calcification, it tends to be periventricular and it tends to be thick and chunky. And the rest of the calcification is kind of fine and punctate. And if you've had CMV also in utero, for example, you're going to have other abnormalities probably. So I won't go through them, but it's not just calcification if you've had CMV. Toxo tends to be basal ganglia and corticomedullary junction. So pattern of calcification can help. CMV, as I say, periventricular, and with other lesions, and toxo, basal ganglia and sort of peripherally. This was a young child, 2 months old, who had these multiple foci. So some of these look subarach, some of them look parenchymal. This looks parenchymal, and it's involving the sort of caudate heads. So a very common appearance of previous infection, having these dots. Could they be calcified emboli? A bit unlikely if they're bilateral. And could it be previous subarach? I suppose it could be, but previous infection is more likely when you've got these sort of multifocal parenchymal and extraaxial lesions. This patient doesn't have edema, which would make you think, okay, it's not a recent thing either. This could be a long-standing infection. So there are other features you can look at to distinguish. Moving on to neurocysticercosis. So this is a parasite and it's from pork tapeworm. So it's associated in areas which have poor sanitation and hygiene. And these patients will present with various things like headache, hydrocephalus, poor mental status and deficits. And they're treated with antiepileptics, and the two most common anti-helminths are not Minthic therapy, albendazole and praziquantel. And they also have steroids because they often have some edema associated with these lesions. So there are 4 stages. So Escobar's pathological stages I'm not going to go through these in great detail. I'll start with the bottom one. So nodular calcified, this is the one we're talking really about today. So none of these stages are calcified. It's the quiescent end stage where you get a calcified cyst remnant. And at this stage, there's no edema. At the very start of neurocysticercosis, you have a parasite with an intact membrane and there's no edema. The second stage, the parasite dies and you get edema. And this is the stage where you're symptomatic. The next stage after that, you still have edema, but it's actually improving. And of course, you'd have follow-up imaging and then you've still got enhancement. But yeah, this disease can produce intraaxial infection as well as extraaxial infection. So don't be caught out thinking, oh, it's only the brain parenchyma, it can't be neurocysticercosis. If you have infection in the subarachnoid space, they can be absolutely massive. They can be up to 9 centimetres. And they can look like a big bunch of grapes in the basal cisterns. The little parenchymal ones tend to be a lot smaller and they tend to be peripheral. But as you can see, they can be anywhere. You can also get them in the basal cistern. So these, yeah, grape-like appearances can be very, very striking actually. And they can also occur in the ventricles, most commonly the fourth ventricle. So the cyst with dot sign, if you see a cyst with a dot, it's almost certain to be neurocysticercosis. So you need to go sort of rooting around for the history for these. There are 2 stages where you might see this cyst and dot. So the vesicular stage, this is the very first stage. So this is the cyst, obviously, with low density fluid. And the scolex is the little bit in the middle, which is a bit denser. And it's not calcified, it's just dense at the moment. And then the stage after this, if you give contrast in this patient in a later stage, you might get enhancement, and you might get enhancement of the scolex, of the wall of the cyst and the scolex. But in the next stage, you'd have some edema surrounding that. Well, this would be classic for neurocysticercosis. And this is the quiescent stage that we talked about earlier. So if you see this, what's the differential? Well, it could be Mets. It could be old abscess. I think the extent of these would be against it being abscess. You can get, obviously, from endocarditis, multiple microabscesses. I still think it would probably be unlikely to be abscesses in this case because there's so many. Tuberculosis for sure, previous amoebic infection, and then other bizarre parasitic infections. It's not particularly uncommon. So you want to, again, patient age, other history, previous history, check other imaging. So people with neurocysticercosis might have calcified bits elsewhere in their body. So, and then finally, on vascular calcification, this is just an example of Sturge-Weber. So these are patients who have a hemangioma, usually ophthalmic division of the trigeminal nerve, and it's like a port wine stain. And they have peel or leptomeningeal angiomas. And this is what you get on an axial CT, so atrophy of the brain. You get this tram track and gyriform calcification. And we talked about this last week, but the atrophy is because the abnormal AVM or peel AVM is stealing blood from the normal brain. So it becomes a bit ischemic and a bit atrophic. The other thing that you can get in Sturge-Weber is that you can get enlargement of the dural venous sinus. So it's worth looking at the dural venous sinus in these patients and also looking down at the ipsilateral lateral ventricle because the choroid plexus can also be enlarged. So it's really a combination of findings in these patients. And then, so we've covered vascular, neoplastic, a bit about infection, these old abscess, old infarct, old hematoma, they can all calcify. Infarct is probably the commonest of those. I haven't showed tuberous sclerosis or NF1, NF2, but these can all have subependymal nodules, etc. And then you've got all these things that the neurologist will see, which can cause calcification. So let's park calcifications and move on to post-operative appearances and complications. Probably more neurosurgically orientated as opposed to old TB or neurodegeneration. So I'm going to talk today about burr holes, craniotomy and craniectomy, what they look like and where they should be, and then some complications that you might, or we all might see after surgery. So I thought we'd start by looking at normal scalp anatomy on CT, and then I've got a pictorial to show the layers of the scalp as well, because I think it's quite a basic thing when you're describing something on a post-op CT to think, okay, which layer is it actually involving? So on a CT, this is an axial, obviously. You've got this hyperdense line at the superficially, so this is skin. And then you've got another line here, so there's temporalis fascia, or the sort of aponeurosis. And then you have temporalis muscle. So these are the three things that are dense. And you'll see in the next slide what's in between. So in between the skin and the fascia, you have this little bit of fat here. So this is subcutaneous fat. Fat on a CT is sort of intermediate. So it's not as dark as air, and it's actually not, it's more dense than CSF. And then underneath the fascia, between the muscle and the fascia, you've got the subgaleal layer. It's here. So these 5 layers really. This is the diagrammatic showing, this is a coronal. And of course the mnemonic is scalp, S-C-A-L-P. So S is for skin, C is for connective tissue, A is for the aponeurosis, L is for this loose areolar tissue, and P is for periosteum. So if we go back to this one, this would be S, this would be C, this would be A for aponeurosis, L for loose areolar tissue, and then P would be obviously here in a normal person. So let's just move on to what you might see after, or what you will see after surgery. So burr holes look like this. So they are pretty well rounded. They involve the outer cortex and they extend into the diploid, but they don't, yeah, that's what they look like. And you might see a bit of fluid. This is a fluid level. So of course the patients are scanned on their backs. So you'll see a fluid level when they're lying on their backs at the back of the burr hole. If you see this, it means you've put bone dust. I don't see bone dust in burr holes very often. And you can have also these titanium covers covering the burr holes. So that's something else that you might see on a CT, wondering why there's so much high density. So there actually might be a cover on the burr hole. So what are the intracranial complications we might see on imaging? Infection, skull fracture, hemorrhage, and for patients who've had burr holes, so plunging. So plunging is breaching of the dura, and of course this can produce parenchymal intracranial hemorrhage. And I thought we'd just briefly go through the 6 different types of craniotomy to show where we're expecting to see the craniotomy and the burr holes. So the circles on these diagrams are actually the burr holes. So this would be a pterional, or it's quite a common craniotomy, or frontospinotemporal craniotomy. This is more lateral, and this is called a subtemporal craniotomy with 4 burr holes. You can have parasagittal. So here's the nose. This is again volume rendered. So here's the coronal suture here. This is probably lambdoid suture back here. And this is the parasagittal, more anterior, I suppose. And you can also have a suboccipital. So again, this is the occipital protuberance. This is the sort of mastoid tip, volume rendered. This is the back of the head. So this is a lateral suboccipital craniotomy. And if we go slightly more medial, again, this is the back view. So here's the lambdoid suture, external occipital protuberance here. So this is the median suboccipital craniotomy. This is what we see a lot after somebody's had surgery. So this was after a pterional craniotomy, so the frontospinotemporal type, and you can see some swelling in the subgaleal space, superficial to this craniotomy. And it's difficult on CT to distinguish here, you know, is there CSF here, is there blood, is there edema? So blood tends to be in the acute phase, hyperdense on CT. So presumably this bit is blood. This bit could either be a bit of older blood, which has been there for a few days, for example. It could be a mixture of blood and edema, or even a bit of CSF. Quite hard to distinguish exactly the contents. And then if you look deep then to the craniotomy flap, this is really common. So most patients after a craniotomy will have this. They'll have some changes deep to the craniotomy. And it can be quite difficult to say if this is extradural or if it's subdural, but usually it's extradural. This is a patient who has had bone flap, and just to say that after a craniotomy, the bone flap margins are usually straight and they're usually really well defined. So if you see somebody like this, it's got sort of more rounded margins. It means that the craniotomy flap is undergoing a bit of remodeling or resorption. So this is longer standing. Again, this rounded appearance rather than a straight appearance. And it's the same on the other side, quite rounded margins. This is an MRI actually, just to show you, again, trying to distinguish which compartments everything's in. So if we start superficial to the bone flap here, you can see this is the bone flap here. So this is, I'm showing an MRI, but this is T2 is dark. You can see these are the margins, posterior margin, anterior margin, normal calvarium. And then you can also see here, so you've got skin here, and then you have this subcutaneous layer here of fat, which is bright on T2. Then you have the aponeurotic layer. So that's your the SCA. And then, so this is subgaleal. This fluid is subgaleal and it's superficial. And then if we go much to the most medial part, this is obviously left parieto-occipital region. This black bit here is the dura, and that's typical of what you'll see on an MRI. And then you've got this fluid here deep to the bone flap, which is extradural fluid. So subgaleal and extradural. Could that be subdural? Well, it's lentiform, so it's less likely to be subdural. Because it's, it's lentiform, it makes it more likely to be extradural. And you can also see the dura. So what else might we see on just post-operative patients? Well, dural enhancement, you don't see it so well in CT, which is why I'm showing you here a coronal post-contrast T1. And this is what you'll see in normal cases. So it's thin and it's linear and it's not nodular, and it can appear really early within the first day, and it can last basically for years and years and years. So they're saying up to 40 years. And if, of course, you've got a meningioma, it can be quite difficult to say, okay, is this a recurrent meningioma with dural involvement, or is it actually post-operative? So it's all about looking at the previous imaging and looking at the follow-up imaging. And yeah, it can be very widespread. It doesn't have to be just deep to the flap. It can actually be bilateral, sort of pachymeningeal enhancement everywhere after surgery. Pneumocephalus is really common after surgery, and it's usually frontal, and it's usually subdural. And then if you see this air sneaking along the falx, it means it's actually subdural rather than extradural. So parafalcine extension means it's subdural, and this will usually resolve in a few weeks. But of course, it doesn't have to be subdural. It can also be subarachnoid pneumocephalus. Much less common to see subarachnoid. I've highlighted in orange here this neurosurgical emergency. So tension pneumocephalus, it's pretty uncommon, but it can be life-threatening, and it's due to a buildup of pressure. So there's pressure within these collections, and it's pushing the brain, and it's usually, it mostly occurs after posterior fossa craniotomy. And what you see on CT is this peaking sign, or Mount Fuji sign. So the frontal lobe looks a bit like Mount Fuji, so it's like little mountains, peaks here, and you've got compression of the frontal lobes. And this interhemispheric space widening here is also a sign of subdural extension from both sides. You can also see tension pneumocephalus after you've had nitrous oxide anaesthetic, and that's when you've had pre-existing pneumocephalus. Now, the diagnosis, so this is actually quite common. When we as neuroradiologists will comment on a report as being, a neurosurgical emergency, but the patient doesn't have to be symptomatic, which you will know, and you can only diagnose this tension pneumocephalus if the patient is clinically deteriorating along with imaging findings. And these can be treated either with oxygen or with aspiration or drainage. So moving on to from infection, pneumocephalus to infection. So what are the potential infections you can have on CT? Well, meningitis, you're not going to see very easily on CT. Extradural abscess, for sure. Subdural empyema, you can probably infer. And brain abscess, yes, it's useful to look at the CT. They're pretty uncommon and they usually start at the line of skin closure. Now, if a patient has cellulitis, that's a clinical diagnosis. So what is the role of CT, for example, or then subsequent MRI in these patients after surgery? Well, it's to look at the bone flap involvement, extraaxial spaces, meninges, brain, and dural sinuses. So if you have infection, and it spreads into dural sinus, it's possible to have thrombophlebitis, which produces a dural sinus thrombosis. So bone flap infection, it usually occurs early after surgery. It can be months, and it usually starts with a superficial wound infection. And the detached ones are more likely to become infected, and usually they are Staph aureus. So I think it's important clinically to know if they've got a wound infection. Somebody without a wound infection is unlikely to have a bone flap infection. Bone flap infection is much more common if you've had an intraoperative CSF leak, if you've breached the sinuses, if you've already got an intracranial infection, if you've already got some sort of contamination, so compound fractures or stabbing, or if you are immunocompromised in some way, for example, if you're on steroids or whatever, if you have concurrent systemic infection, and if you're operating for longer, you've got an increased risk of bone flap infection as well. So this is what it might look like, but it might not. So CT, I'll skip to the next slide. You can't really determine on CT alone if infection isn't present, because you can have these lytic looking areas and abnormal texture and abnormal sclerosis, whether there's active infection or in an old uninfected bone flap. So the supporting features that you need to look for, so skin thickening would support bone and flap infection, as would increased fascial attenuation, and then fluid collections. So if you have a fluid collection either superficial to the flap or deep to the flap, and if it's getting bigger, then it's much more likely that this patient has infection. You can do an MRI, but again, if you don't have a subdural collection, difficult to say. So an MRI bone flap might look edematous, but without any of this, very difficult to say, even using MRI. For a collection, it's different for a subdural or whatever. So in terms of infection as well, let's talk quickly about extradural and subdural. So extradural abscess, I never quite understand why they're not called extradural empyema. So it's always subdural empyema. But extradural abscesses tend to have a lenticular configuration, and they're underneath the bone flap. What you see in abscesses is this thickened dura, and its enhancement at the deep margin of the flap. So that's quite common, that's quite characteristic of an extradural abscess. I often feel that we get asked to do a lot of post-op imaging, is there a extradural abscess or a subdural empyema? And the dura can also enhance. So I find it quite difficult in a lot of cases to actually be very definitive about whether this is infected or not. I think, again, clinical signs would make me push me towards telling you guys that it was infected, not just the presence of a little bit of dural enhancement. So in terms of these empyemas or abscesses, extradural is much more common than subdural. If you have an extradural abscess, then a few people will also have subdural empyema associated with that. Clinical presentation of these abscesses is much more indolent. They don't necessarily occur early, so they can occur quite late, and almost all of the patients show wound infection. So again, I'm highlighting that to try and point you towards the fact that imaging findings can be a bit non-specific. Only the minority have fever and headache, so not particularly helpful sign. Here's a subdural empyema. So this is a crescentic collection rather than lenticular. And these tend to occur obviously deep to the flap, along the convexities, can be parafalcine, falcine even. Again, this is quite characteristic, having rim-like enhancement medially. But you might not see this early, and you might not see it so clearly on CT as you do an MRI. I think the other thing you need to consider when you think you might have an empyema is to look for any cerebritis or sort of early abscess formation in the underlying brain, which can be a really good marker for this being a subdural empyema rather than just a bit of fluid after surgery. Just to mention MRI, because I mean, these patients often have MRI and we've talked about them in CT. They are low on T1, bright on T2. Now this is a T2 here. This is the same patient actually as the one higher up. They will have restricted diffusion and rim enhancement. So I'm going to show you the diffusion. So the two sequences you need to look at on MRI are the B1000 and the ADC map. So what you'll see here, if it's bright on the B1000 and it's dark on the ADC, this means it's restricted. And you'll see that actually not the entire collection here is restricted, it's only little bits of it. And we often see that, you know, it doesn't have to be homogeneously restricted. It's the same with brain abscesses. Sometimes you've got a bit of necrosis or blood within them, so it's not always as straightforward as you might think. Anyway, that's restricted diffusion. Basically, if you consider CSF as being normal diffusion or free diffusion, and that's black on here, it needs to be the opposite, so white. And on here, CSF is freely moving, so it's white, and it's the opposite on the ADC, so black. Extradural hematomas, so much more hyperdense. This is acute blood on a CT, and it's between the periosteal layer of dura and the inner table. So this is what it looks like. And these can be classified into regional, adjacent, or remote. And it can be due to problems with hemostasis at the margins, so for example here and here. Or it can be due to failure of the fitting the sutures to the centre of the bone flap. The other thing I'm going to mention is this thing called remote cerebellar hemorrhage. I've never seen it. You guys probably will have. It's rare. It's usually when you've had a craniotomy supratentorially, and they are pretty unwell, these patients, and it's because they end up with depletion of CSF, their cerebellum sags, starts to sag, the bridging veins then become occluded, and you get what this is called this hemorrhagic infarction. So you get this zebra sign. So this is blood, acute blood, hyperdense blood in the cerebellar foliae, zebra sign. And this again is a something to look out for, which is pretty rare. This is a patient with what's called an adjacent extradural hematoma. So when you call it adjacent, it's not just deep to the bone flap here, it's normally at the margin. And it's usually posterior. So in this case, it's actually the anterior margin, adjacent extradural hematoma. And usually it's because the brain has collapsed. So for example, if you've done a rapid drainage, taken a lot of fluid out, the brain can collapse down here and you get sort of extension or gravitation of blood into this region where the brain has collapsed. Again, it's more common to be posterior. So you might expect this extradural to be here, more likely. Finally, just a few slides on craniectomy. So this is removal of a portion of the skull, and usually it's because the bone flap's infected or there's tumour of the bone, or you can also use it as a part of a suboccipital craniotomy to avoid posterior fossa swelling and issues with that. Decompressive craniectomy can be performed if you've got hypertension. So this is obviously a bit non-specific, can be after traumatic brain injury, often malignant MCA territory infarcts, often young patients are after subarachnoid hemorrhage. So basically raised ICP. You can have a bilateral craniectomy or unilateral, and if you tend to do a unilateral one if you've got a unilateral hemispheric swelling and you've got midline shift. And it's quite extensive, so frontal, parieto-temporal, so usually large craniectomy. And craniectomy you will either close the dura. However, if you do close the dura, the intracranial contents don't decompress so well. Or you can actually use you can do duroplasty. You chaps all of you will know better. You guys will know better than me about allograft and artificial graft patches. So on imaging, it depends on what's happened to the dura. So, excuse me. So if the dura has been left open and it's sutured to the bone margins, and then that isolates the subdural space, and that will limit the spread of any post-op fluid collections. If the dura is open, the subarachnoid space might herniate through the defect, and this can cause a pseudo-meningocele, and we commonly see that in patients who've had suboccipital craniectomy when the dura is open. This is what we'll see on axial CT after a craniectomy, so obviously intact bone here, bilateral craniectomy here, so no bone. And the subgaleal space, which was so nicely demonstrated on that pictorial, has now been obliterated. And what's in its place is this, what we call meningogaleal complex. So this on a CT, it's basically a combination of 4 things. So you've got galea, or the aponeurosis, you've got a bit of connective tissue, subgaleal connective tissue, probably a bit of scarring, and also a bit of dura. So you cannot separate these, obviously. So the pictorial from earlier, you can still see skin here, and you can still see a bit of fatty subcutaneous fat here as well. But the rest of it is actually just one big complex. And this is what it looks like. So it's usually 2 to 4 millimeters. It's quite thin, it's curvilinear, and it's relatively hyperdense, and it might enhance. But this is normal appearances. This is a patient who'd actually had traumatic brain injury, which is why they've got these multifocal bifrontal areas of low density. Then what you also see in this patient, apart from the sort of old sort of contusions in the frontal lobes, this is some subarachnoid blood deep to the meningogaleal complex. So that's subarachnoid blood, subarachnoid space. What are the complications? Well, if the defect's too small, the brain could just squeeze right through. That is a problem because the cortical veins are then compressed, and this can cause infarction. So if you see somebody that's got a big herniated brain or a big piece, a bit of frontal lobe popping out through the craniectomy defect, and there's lots and lots of low density on CT, it might be because, not because of their infarct or traumatic brain injury, it might be because they've had a venous infarction. And they can also get some contusion of the brain. So these patients can often have very, very complex appearances on axial CT head. You can also have subgaleal and subdural hygromas. They're usually on the side of craniectomy. Sometimes they're interhemispheric. They usually appear early. So in this case here, so bifrontal craniectomy here, we've got a mixture of subdural, crescentic fluid, interhemispheric fluid collection, and subgaleal fluid collection. And same on this side. So this is subgaleal, this is subdural. The other thing that can happen is tamponade. So we sometimes get asked to scan a patient because the flap feels tense. You know, is there an underlying collection which is tamponading the brain? And often there is. Sometimes it's just brain hanging out. But this is potentially life-threatening, and it's because this subgaleal fluid here is under pressure, and it produces this tension of the flap, and it can produce mass effect on the brain. So you can see, you know, the brain isn't allowed to herniate out because of this fluid collection. And these patients will improve after drainage. And the final thing, which two things I'm going to talk about. So a sunken flap, this can occur, usually it's not early, it usually occurs sort of at least a few days or weeks or late post-operatively. And the patients actually have symptoms from this, and the skin flap will be sunken. So you have this appearance here. It looks like a sort of sigmoid shape, and it means that the brain contents have been exposed to atmospheric pressure. So the CSF dynamics change, and then you end up deforming the brain here, as you can see, in an abnormal way, and it reduces cerebral perfusion. So these defects tend to be therefore, or need to be repaired with a cranioplasty to improve clinical symptoms. And the final thing I'm going to tell you about is this other neurosurgical emergency, which, so this is craniectomy, so sunken flap, and instead of the brain being in the midline, there's midline shift to the right, so there's subfalcine herniation here, and there's also transtentorial herniation. So the basal cisterns here are effaced, and the midbrain is being squished side to side. So this is, and they've also got some blood in their temporal lobe. I think it was a traumatic brain injury. So this is called paradoxal herniation. You've got a big defect, but the brain is herniating to the other side. And these patients present with brainstem dysfunction, not surprisingly, and they require urgent treatment. So the pressure needs to be increased, the CSF leak needs to be stopped, or you need to restore the continuity of the calvarium. So that's paradoxal herniation, and there we are. So just to summarise what we did talk about, we talked about hydrocephalus last week. The key points for assessing hydrocephalus, we said, okay, is it an acute thing? Check periventricular low density. Check sulcal pattern. So is there atrophy, for example, producing big sulci? We looked at a case of NPH versus atrophy. We looked at normal calcifications, abnormal ones. It's really important to interpret these in conjunction with the age, history, clinical findings. You're not always going to know what an intraaxial neoplasm actually is until it's been biopsied. And then post-operative findings, what normal scalp looks like, typical types of craniotomy and craniectomy, and the sort of complications, and how to look for other associated features, particularly for infection, and how to distinguish between the compartment, with extradural being much more common than subdural. So there's some references. I will stop there. Are there any questions at the moment?
Hi. Sorry, you know, towards the end you showed the the fluid in the midline. Was that kind of an extension of the subdural fluid collection, or was that separate?
I don't remember that actual case, to be honest. I think it's possible just to have interhemispheric without having subdural as well.
Oh, I see.
It's pretty uncommon.
Because there was a lateral subdural collection and then another collection.
Yeah. It's usually contiguous. It's usually contiguous. Yeah. Well, I hope that was helpful. And if you do have any other questions, just feel free to email me. I won't hold you anymore, and enjoy the rest of your afternoon. Thanks very much for coming today as well online.